Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So welcome to February. I can't believe we're here already, but here we are, and we are going to talk today a little bit about part of an E&M service. So we know that the E&M has different things now. I mean, we have to have a problem-oriented history and physical. We know that, but I don't use that to level the code. I use that to make sure that it's medically necessary. But in saying that, we notice that a lot of times people are missing the understanding of the medical decision-making and all the elements that go in there. We've got number and complexity of problems addressed. You've got amount and or complexity of data to be reviewed and analyzed, not just listed. And then we have the risk of complication and or morbidity or mortality of the patient management, which is the assessment plan risk. And that's what I'm going to actually focus on today. I just want to talk to you about that a little bit because I feel like when we look at the element 3 or complications, or the third element of medical decision-making, risk of complications of patient management, the physicians feel that just listing, for example, prescriptions is enough to meet a moderate for the entire visit, and that's not the case. The third element of medical decision-making, again, is risk of complications and or morbidity or mortality of the patient management. So what could happen to them from what you plan to do? And this is either minimal risk or morbidity from additional diagnostic testing or treatment for low medical decision-making, such as supportive care, minor procedures, or over-the-counter medication, physical therapy. Moderate risk can include prescription drug management, but remember, management, do you have script authority or are you just mentioning something somebody else did? Then that doesn't count for you. It could be decision for surgery without outside risk factors or diagnosis or treatment significantly limited by social determinants of health that impact what that patient can get or can't get, meaning, are there economic or social conditions that influence the health of certain patients in their communities? And it's important to document and report those ICD-10 codes for these conditions, not only to support the E&M service, but also for quality measures, for risk adjustment programs, as well as data collection for public health. And there's a lot of ICD-10 CM codes for social determinants of health. For example, I mentioned economic social conditions. There's homelessness, financial resource strain, tobacco, alcohol, and drug use and abuse, lack of social connections, depression, stress, lack of education, and lack of access. Homelessness is a really big deal when it comes to being able to access medication that's been prescribed. So things like that, that's when you get into the difference between the minimal risk versus the low versus the moderate. And then when we get into high risk, that could include drug therapy requiring monitoring for toxicity, not monitoring for at goal levels. So if you're monitoring a patient who happens to be on Coumadin, that's not considered monitoring for intensive toxicity. That's monitoring to make sure that their INR is appropriate. And so we have to really look at that. But first, we want to thank our sponsor, Blackout Coffee Company. I just bought the butterscotch toffee flavored coffee. This is a conservative company, only conservative services out of this company, and we appreciate Blackout Coffee and their fresh roasted flavors. blackoutcoffee.com. So back to the high-risk drug therapy, as far as a high risk, maybe, that would affect morbidity and mortality in a patient. So again, the monitoring is not for therapeutic benefits, but potential side effects. Maybe there's liver damage, that somebody could get from the drug that they're on. The intensive monitoring should be done on a regular basis, not every 3 to 6 months. That's routine monitoring. So surgical decisions, maybe, that also could be included. Again, this is the third element, not the entire medical decision-making process, but this is the third element. Surgical decisions that include patient or procedure risk factors and emergency surgery are also high risk. But remember what we're talking about here. It's not the routine consent, and guess what? Every surgery has a risk factor. It's surgical decisions that include patient procedure risk factors for that patient. So, for example, the decision to hospitalize a patient may be considered high risk if there was a decision maybe to stop treatment and initiate palliative care, supportive care because of their poor prognosis. Or let's say that the patient needed to have gallbladder surgery, but because the patient is on blood thinners, had a previous pacemaker placed, they're going to have all kinds of pre-ops done because of their clinical profile. But you've got a 45-year-old otherwise healthy patient who happens to have gallstones, and you are scheduling them for, again, a routine laparoscopic cholecystectomy. That's not necessarily high risk. So I see that a lot of times when I'm not seeing the thought process of the physician well documented, because typical behaviors and thought process of physicians or other QHPs, qualified healthcare professionals in the same specialty, they have to define the risk. For medical decision making, there is risk to problems addressed, but that's element one. And then there's a risk level that is based upon the consequences of the problem being addressed at the encounter when it's appropriately treated. So I know sometimes that's hard to understand, but also think of it this way. Medical decision-making related to the need to initiate or forego further testing, treatment, or hospitalization also falls under that third element or that umbrella of risk for morbidity or mortality of the patient. So if that discussion of what the patient needs to have as far as the next step in their treatment, let's say I was just auditing some cancer records recently, and the patient's declining chemo, patient's declining certain things, they just want to be kept comfortable. These risk factors would support the level chosen, whether the test or treatment is chosen or declined for the patient. It's the provider's thought process and their work involved that really counts when we're looking at that third element of risk for an E&M service. And it brings me also to, and I hate to talk about this all the time, but the G2211, I'm seeing this added actually a lot more by nurse practitioners than I am physicians. And I'll see a physician note, and I'm like, this is perfectly qualified, because let's say you have a patient who has all kinds of clinical issues. Let's say you're their cardiologist, and you're dealing with their peripheral vascular disease, their CAD, their diabetes, their hypertension, and all of their medicines that are involved in monitoring or trying to manage those conditions. And the patient says, I need cataract surgery, or I need dental surgery. And there has to be a decision about what kind of anesthesia they have that could be a problem with whatever medicines they're on. That means that your longitudinal relationship with the patient and for that complexity of that patient was necessary to determine if they can be approved or not, or what adjustments need to be made. But if the patient's coming in at goal, looks great, no problems, PRN 6 months to a year, and there's really not something that your expertise needs from a complexity situation and a decision today, because they are a good, they're doing well. It's a good checkup. It's 99213. Even if you make it to a 4, don't always add that 99 or that G2211. It's not appropriate. And then the one thing that also I just want to mention when we talk about this risk, remember when we are looking at the risk, if you are ordering a test, and I know I talked about actually on the hashtag Dairy Tuesday with Sean Weiss podcast, I know we talked about they're looking at data. So, I'll see simply adding to a record, chest x-ray negative, okay? And then they also tried to, or they also billed for the x-ray. So you can't double dip, you don't get both. But let's say that you billed for the x-ray and it showed something. So what the treatment from that x-ray, that now falls into the complication or risk if there's something that's on there that was positive, and maybe there was some kind of a lesion seen, maybe there's something on that's a concern, maybe near the lungs or something, or tuberculosis or whatever, then that moves a different category. It's not now trying to get credit for data. Now you're looking at risk of what you're planning to do based on that diagnostic test. So always look at the entire 3 elements before you choose your level of service, because I see too many level 4s being flatlined, and I mean 99204 or 214, because the patient comes in with 2 at-goal chronic conditions. There's no complaints, no problems, asymptomatic, and the doctor says, continue medication. And that, no. You have to show the status. You have to reflect that, today there was something there that, yes, they may be stable, but are there other issues that you addressed along those lines with those chronic conditions that are more than just stable chronic illnesses? And then you move on to, did you do any data? No. Okay, well, you might have gotten into a level 4 to start with the 2, or more stable chronic illnesses. But then when I look at the risk of complications and a morbidity, and all I see is continue meds, that to me is not. And again, I know that auditing can have a lot of subjectiveness to it. It's not always objective, but to keep you safe, to keep you, to make sure that you're not going to have money taken back from you, because there are a lot of MACs out there, a lot of private payers that are really starting to scrutinize E&M codes. You really have to make sure that you are looking at that third element, that risk of complications or morbidity, that reflects exactly what you're doing. Examples where it just says, prescription drug management. What does that mean? You're managing the patient. You're saying the outcome, why the dosage, the date is in there, how long they're going to continue to be on it, if any adjustments need to be made, and how they're doing. You need to show the management, not just the list, or it reverts back to the history. So I just want to have you keep that in mind when you are, again, looking to refresh maybe your compliance policy, or talk to your physicians if you're starting to see a trend where they're saying, well, we're losing money, so we're going to start billing more of this service, which I see that a lot too. It's like, we need to up our codes or up code because of the financial situation. Don't do that. You can't do that. I just got a question recently from a Coding Corner client that basically said, so the doctor did a debridement, just a small one, and they found out that the level 4 visit pays more than a debridement, so can we just bill that? Well, no. What if the patient's care had to get elevated, or there needed to be pathology, or there needed to be something from that procedural encounter that had to be opened up or extended, and you don't have anything about that. You just have an office visit, and you never want to bill for something based on reimbursement anyway. Otherwise, that can open up another can of worms. It's based on what you did. Even though it may pay a little less, you bill what you did, and that just keeps your claims clean. Otherwise, there's definitely going to be some issues there. Okay, well, that is, I know it's short and sweet this week, but I just wanted to really touch on that last element of medical decision making. And I may go into time at some point, but I'm going to get back to some specialty coding starting next week, and really just keep back to the, why I started the Codecast podcast, and get back to some coding options. For those of you that didn't know, this week is the first week, so February 4th, 5th, and 6th, that we're doing the boot camp for NAMAS, the National Association of Medicare Auditing Specialists, the boot camp for the new credential for telehealth, certified professional auditor telehealth boot camp. So you can prep for that and then take the test. And it's something that I was a brainchild of mine about 3 years ago, brought on Christine Hall, and her and I will be team teaching those boot camps. So the first ones for the week, and they're limited to only 20 people of camp. So we have one this week. I think we're sold out. And then we have one coming up and then in the next couple of months. So we have 4 this year, and we're pretty excited to get this started. So take a look. It's NAMAS, NAMAS.co, and see if that's something you're interested in. We hope you are, because we're very excited for this project. It finally came to fruition, and we're excited to get this started. Personal tidbit, yes, the Super Bowl is not who I'd hope were in there, but it is the Eagles and Chiefs, and it is February 9th, and if you're watching, who are you going to vote for? We'll see. You're going to bet on it? Let me know. All right, everyone, make it a great day, make it a great rest of your week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.